So good afternoon. It's great to be with you today. Value on investment, funding models to support modernization of healthcare infrastructure. You know, this topic is going to fit in nicely with our discussion. I think over the last 2 days, it's been a great forum, a lot of great discussion. We've really heard a strong message, I think, about across Canada, we share a vision. And that vision is integrated, patient-centered care that connects patients with their information with their care providers, and care providers with each other across the continuum. So that vision, while attainable, we're getting there, is dependent on a convergence of a number of factors. And in this session today, I think we're going to talk about the funding sources and some of the models, policy and governance to some extent, technology implementation, and sustainable management, capturing the value on investment and where we go from here. So we've got three great speakers with us. I'll introduce all three to start in a moment. My name is Mark Casselman. I'm CEO at COACH, Canada's Health Informatics Association. And COACH is the voice of health informatics in Canada. We're a group of 2,000 members representing technology, clinical, and the business side of digital health in Canada, promoting the adoption, practice, and professionalism of the discipline. And so the work that's being presented today comes out of one of the forums, CHIEF, Canada's Health Informatics Executives Forum. It's 100 leaders from across the country, representing both public and private sector, coming together, CIOs, CMIOs, and leaders that debate, talk about, and think about some of the leading topics and do collaborative work in between those sessions. And so what you'll hear today is a result of two of those leading papers.
So I'm going to give a sort of a very brief overview. I could discuss this at much greater length in much greater detail, but I don't think we want to get too caught up in the details here at this forum. Here we go. So I just have a few slides to set some discussion. As I said, it could be presented. It's a much more detailed dialogue, and if you look at the papers produced by the group, there's lots more detail there. But basically what we wanted to do is frame value for investment and to discuss how we continue that investment. One of the themes of this meeting has been how much progress we've all made, and yet we still seem to have to keep going. So one of the contributions that our group had to the dialogue around value was to frame it both in terms of clinical and business value and suggest that the analysis can be separated, right? And this separation ties to a much bigger conflict that existed inside the CHIEF group. We started out with this big argument, right? Some people said there is no return on investment for healthcare IT. And then myself and others said, of course there is, right? And what turned out we were arguing about wasn't whether it was value or not. Is a lot of the original framing arguments were about, is there a business case wherein the investment could be recaptured over time? That does not appear to be the case in any analysis that anybody has been able to put forward in concrete ways. That the magnitude of some of these investments, the magnitude of investments many of you have already made, has been substantial, and pointing to a payback in dollar terms may be hard to do, or certainly hard to defend. I could put a stunning statement up here and a number, you could shoot it down. Let's put it that way, right? But when you separate and say, okay, there is a certain dollar return you get from this, that's the business value alluded to here in this slide. And there's another portion which is clinical value, which cannot be turned into a monetary value. Yes, adverse events avoided mean less lawsuits. Yeah, I know. But it's hard to really defend that in dollar terms, and most healthcare executives or funding agencies aren't. Most of you haven't had the experience that anyone has ever bought it, right? You make that argument, there'll be less lawsuits. Nobody seems motivated by that, right? But that doesn't mean it's not the right thing to do. Right? Making patient care safer is the right thing to invest in, but let's just not treat it as dollars. Right? So that's why the separation into clinical value, or clinical VOI as we call it, and business ROI. Right? So that was one of the things that I think is important to think about, and I can talk about this in much greater detail. I have a couple slides about it, but really it's a much bigger discussion. The little cartoon at the bottom of this slide is, I actually alluded to this a little bit yesterday. I keep saying to people, the idea is not that there is a business case for this, but rather that where opportunities exist to save dollars, we can therefore transfer or transition those dollars to help us achieve the clinical value, which cannot be commoditized, right? So the notion for our hospital, for some of your organizations, for jurisdictions is save money where you can, and there are things you can save money on, and then invest that money in things that are important, like patient experience or patient safety, adverse events, avoidance, things like that, right? So that's really what the cartoon is meant to suggest, and there's a balance between those things which can be shifted if we apply our strategies in rigorous ways. And as I say, it's part of a much bigger discussion, but that was the intent of this little picture. So examples of business return on investment, which we have discussed, and this is not news to you, but you can put numbers to these things. You can, right? It's very clear. Elimination of paper, elimination of transcription costs, eliminating manual process steps, eliminating duplication, inappropriate testing, all these things, and you can find literature pointing to organizations that have done this, and you can take that literature, and what we had to do at our hospital is normalize that information against the size of our organization, right? And every organization was going to have to do it for themselves, and you had to take a conservative, well, you know, if this, let's take transcription costs. Well, if you can reduce the need for transcription by 80%, what would that leave, what would be the dividend which our organization would receive, right? That's an example of what you can do. And so I'll show you a figure for that in a second. So these are all things which you can get information from other organizations, either published or you can call them up and get this information, and we've done some of that. And it does give you an ability to quantify in dollar terms some of the things you're going to get, right? Depending on the state of your organization. What else can you do? You can actually come up with a figure, as I said. This is an analysis we had. It's undertaken by some of the folks at Deloitte who applied these principles to our organization. We had already done our transcription transition. That was a $3 million annual saving for the Ottawa Hospital. That was in the past, so we couldn't argue for that for the future. We have already done CPUE for DI. Our CPUE process for diagnostic imaging is paperless end-to-end and achieved FTE reductions in diagnostic imaging or transfer of FTEs within diagnostic imaging to other tasks. And there were significant savings associated with that, so that's in the past and does not appear in this figure. But this is an example of analysis, and as I could speak more at length about each of these items, but didn't want to focus on that here. I'll do another session on that another day. So it's real dollars, and once again, you have to adjust the size of your organization. But the investment required to achieve this means that even though that is quoted there at $11 million operating cost reduction for the Ottawa Hospital, and this is a conservative estimate, this is easily defensible, the figure's probably bigger than that. We're not going with a bigger figure, we're going with a conservative one. You can't get a business case to pay for the scale of investment from that number in any reasonable period of time which external industries would accept, right? It's not there, right? Is that fair? What else can you do? And I argue I've made this argument to the hospital. This cannot be quantified as yet, but probably could be if we all worked on it, is capturing information about patient complexity gives you the opportunity to be recognized for the effort you're making directly for patient care. Since we're funded, every province has a funding agency, you are in a better position to make an argument about the value of the services you provide if the technology allows you to capture the true complexity of care. So this cannot be quantified, but I argue that the case weighting of organizations would more accurately reflect the work they were doing if you put this type of infrastructure in place. Right? So as I said, we did not attempt to come up with a dollar figure for this. but it is a significant business value because if the case weighting is more accurate, you're getting paid for the services you're delivering in a more accurate way. But once again, how to put a monetary figure on that, I don't know. So that's also part of business ROI. Clinical value, and clinical value is the aspirational goals that people at these meetings and the coach meetings have been talking about for years and years, is the things we all think about, and I've already alluded to. Reduction of adverse events, medication management, automated monitoring, automated learning, reminders to clinicians. Many of you have already implemented systems that do this, but these investments are driven by improving patient quality through achieving a clinical VOI. And I think that dialogue is fairly important. And once again, we could go on and on and on with this. Provider satisfaction. We spent a lot of time at these meetings discussing how clinicians don't like change. Some of the presentations at this meeting have identified that no, clinicians will change if you deliver the right value to them. And there are ways to do that which we all need to strive for. Provider satisfaction is important. So it is a value, cannot be quantified, but in dollar terms, but it is an important value we should all aspire to. And patient satisfaction, we've talked about that a couple times this meeting, right? In the end, the patient's perception of better quality care, patient access, who's going to pay for patient portals? Do we believe that there really is a dollar value we're going to put on patient portals? Probably not. But is it the right thing to do? Is it something patients should value? I would suggest that it will. So I'm not sure we could build a business case for them. Maybe. We could discuss that. I haven't seen that discussion yet, but I think we can clearly identify from other sites that have done it that patients will value our investments in avoiding harm, of course, but also our investments in giving them access to their information. So that's where the dichotomy between clinical value and business value seems to be a helpful way to look at the kinds of investments we've already made and investments you're all going to be making in the future. I think that was it. Oh, wait, and this is an example of literature showing us the value we've seen in other settings, right? Same thing is, you would need, all these are expressed as percentages of the impact in other organizations that have done this. They have to be normalized against your organization. And our organization, we don't even really know the baseline figures for some of these metrics to apply the percentage reductions to, which is an indictment of the model itself, right? The fact that we don't know this is the fundamental flaw of why we should be investing in the first place. We should know what our adverse event rates are and things like that. So, but some organizations have done this, and these are the kind of magnitudes of impact they see. In our talking about this within our organization, we've already had people saying, we won't get those figures. I go, yeah, I know. It's just what other people have obtained. What we're going to obtain, we can do the analysis if you want to put the effort into it. They're level setting, right? They're not promises of what we're actually going to achieve, unless you wanted to follow through on a much more detailed analysis of each of the items, right? I better stop. Okay, thank you.
Public-private partnerships, putting P3 models to work for health IT. We really looked at this, and I must say it was a chief working group. I drew the short straw in terms of delivering the content, but most of the work and all of the credit goes to Lindsay Turkett, our emerging professional. Did a great job for the group. When we started to look at this, and there we go. We really wanted to understand, is there a right bundle of assets and services that would actually put a deal together that was large enough to make sense in a P3 initiative and really start to spread the risk around in a way that would encourage both public and private sector to participate. And really, you know, we looked at some of the definitions and key features of the P3. We looked at alternative funding models, and we developed a conceptual model, which I'm going to present here today, as well as a sort of an example of its use. And then really came up with some key findings and recommendations, which, quite frankly, surprised the group. So there's the stay tuned. We went to the Council of Public-Private Partnerships and looked to them to sort of define what a P3 means, and really a cooperative venture, and that's the key element of any P3, is really building the expertise, building on the expertise of each of the partners and making sure that a clearly defined public need is being met through the appropriate allocation of resources, risks, and rewards. Key features. I'm just going to advance all of these here. So the key idea behind a P3 that we're really trying to demonstrate is value for money. So greater benefit to public than if they funded it on their own through a conventional public procurement. And really a large portion of that is accomplished through risk transfer to private sector. Some elements of P3s, or some P3s, look at a financing mechanism, including sort of private financing, project-specific debt and equity, and public sector contribution to the financing of a project at key milestones. And then really a key requirement to make P3s work is really around the contract side, sort of a disciplined procurement process, output-based contracts, and performance-based payments. And then, another element that really makes this a difficult proposition in a health IT solution is the multi-year, multi-phase. These tend to be very long contracts, and the rate of change in IT tends to frustrate the clear definition of the requirements of those contracts. So we came into this looking at a burning platform as to why some change in the CIS and HIS space needed to happen. There was really a key lack of functionality in the legacy systems and integration requirements being driven by the idea of interoperable coordinated care. Limited funding available in some cases from a public sector perspective, shortage of health IT labor, and aging hospital infrastructure. So this is the conceptual model, and we have a number of domains down the left-hand side and a number of components within each domain. I won't walk through them in detail, and certainly the white paper is available on the Coach website, and there you go, Mark. So, props for Coach and their work on this. And really we looked at, for the first 6 rows, the pieces of a particular implementation of an HIS system and what could be included in any new build or retrofit build of a hospital or an IT system as part of that. And then at the very bottom is really the contract model, which looks at everything from finance only all the way down to really an outsourced build owned operated kind of solution. The white paper looks at a number of case studies, and they went anything from a new build hospital all the way out to a cloud infrastructure in Ningbo, China. We focus for this presentation on the Royal Adelaide hospital build in Australia. It's a new build, and we wanted to sort of bring an example to bear that had an informatics and health IT component to it. It was one of the largest P3s to date. It included the delivery of the full ICT system and services. Private consortium, 35-year deal. So, when we talked about the length of contract, this is a good example of the complexity that they're looking at here. And it really, I think the interesting component of it is they were responsible for building and constructing and financing, designing, and even operating components of the hospital, but interestingly enough, none of the clinical systems. And so one of the things they sort of indicated was quite key to their success was the fact that the public sector partner actually operates and is responsible for all of the clinical systems, even if they're sharing the infrastructure behind them. So when we look at this and this model, we really look at who has responsibility and under what contract model those responsibilities were delivered. I won't go into it in too much detail. Suffices to say that in this particular example, most of the sort of hard infrastructure was done by the private sector consortium, and most of the non-clinical systems were done by the private sector consortium. Interestingly enough, they shared the same network for both clinical and non-clinical, and the end result was fairly successful build and implementation there. In terms of the professional services, and I'll sort of point it out that the public sector was responsible for all of the workflow redesign, clinical transformation, and all of the clinical software. And that was a real key, they felt, to the success of ensuring that the risk was allocated to the party that actually had the best chance of success. They had the expertise needed in order to successfully implement. Where they shared some of the responsibility, it tended to divide upon clinical and non-clinical systems. So while they both had application support, clinical was done by the public sector, private sector took care of the non-clinical systems, things like the back office and the like. Flipping forward, our key observations that we really came out with in looking at the 7 different case studies was that the P3 contracting and negotiation process is extremely complex, it's long, and it makes it very difficult to define in terms of health informatics. Health IT changes rapidly and has a real difficulty building those requirements of renewal and ongoing sustainment into a P3 model. That makes the risk transfer in P3 very difficult, which is really non-standard. It's a lot easier to transfer risk around building a physical infrastructure building and the like as it is to transfer the risk in sort of renewal and ongoing IT. There are very limited examples of this successfully being done, and the financing rates and transaction costs are high. You'll often hear governments say, well, why would I borrow money from private sector? I can borrow it cheaper ourselves. So there is a transaction cost here that shouldn't be ignored. That said, some of the recommendations that came out of the white paper was that it was clear that health IT could be bundled into a P3 with a new build. It's been done a number of times. It's routinely done for medical equipment and some of the infrastructure components. And it was very clear as well, outsourcing and operating non-clinical assets made a lot of sense and had the benefit of freeing up capital to allow public sector to use those capital dollars they had to finance directly and operate and maintain directly the clinical systems. And then there is definitely interest and starting to build some case around the use of cloud infrastructure for non-clinical systems and really understanding where that can leverage the technology and capability of private sector in this space. Thank you.
I guess I'd start by acknowledging a bit about the process, and Mark, you alluded to it, the use of emerging professionals. How often do you go to a meeting, like maybe twice a year, and you have this great dialogue, and then you go back to work, and then you come back again and you have another great dialogue, probably something similar to what you had the one before, but nothing's happened in between. And so I commend Chief for ensuring that work was done between meetings. And we had discussed the public-private partnership, or how to change. I think it started off being called innovative procurement, and we kind of morphed it to the concept of P3 as a solution. And we recognized that we kept talking about kind of the same issues, mostly the same people. So we thought this time we'd switch it up. We created the working groups, and Lydia Lee and Leon and I were sort of voluntold to chair them. And the only way we were ever going to get anything done was to have someone who would actually do the work. So I represent Working Group 3, which our emerging professional was Cynthia Chang, and Fraser Edward, who really managed most of the work, and I kind of loosely chaired the committee. There's a list, if you go to the website and you look for the papers, there's a list of who the guilty parties are that contributed to this work. It was not our own thought. It was a consensus of both public and private people. So we looked at the question of what changes needed to happen in order to enable successful P3s. This is the working group membership. I see Susan in the back. I don't know who else is here from our working group, but these folks, if you see them, thank them. They gave their time. They gave their ideas. They didn't always agree, but then that's where we found the most value in putting together this thinking. So we went out and we interviewed each of the individuals, and then we brought them together in a group, and we identified 4 key themes of things that we needed to really tackle in order for P3s to be remotely successful. One was sustainability. And maybe I'll go into each of these in detail in a minute. Second was effective governance that actually respected the contributions and risks of the parties. Building a relationship of trust and true partnership. And this one was fascinating because we all talk about partnerships, but are they really? Like when the chips are down, everyone goes to their corners and they pull out the contract. That's not a partnership. So how do you engender the trust and in the relationship to accept and recognize that the parties have different objectives? Okay? It's okay for the public sector to protect its brand and its image and its being put on the front page of the newspaper, and it's also okay for the private sector to make money. And if we could get over understanding and accepting the objectives of the two parties and making sure that we were aligned on a common outcome, then perhaps we could engender some trust. And then at the end of it all, if we're going to venture down a new path or a sort of different path of P3s, there had to be some assurance of a better outcome at the end of it all. So when we talked about sustainability, what did we mean? What access do we have to cash? And that didn't just mean the upfront cash. In some ways, one-time funding programs are a curse. I'm sorry to say that in an Infoway conference. But in some ways they are, because it's easy to buy stuff. It's much harder to keep it fresh, contemporary, and adding value over time. Agreed. Terry would agree. Thank you, Terry. Whew, got away. So looking at the sustainable funding, it wasn't just the funding up front, but how do you keep it fresh over time, being realistic about, truthfully what it costs for HIS implementations and support and maintenance. Actually, I want to comment on the 35-year thing from Adelaide. How many people here work in institutions that have clinical systems that were implemented 25 or 30 years ago? Okay, so it's not outrageous to think that 35 years is not an unreasonable lifespan for some of these systems. So effective governance. There's an issue of transparency. That's the key word that I was looking for in this definition. If we're going to have effective governance, you have to be able to be transparent with the other party, and to a point where they're not going to run to their corner and drag out the contract. But you have to be able to be honest and open and call out the bad news and call people's bullshit out and be prepared to have an honest conversation about your common objectives and common interests. And while those words are easy to say, I think if you dig deep, you'll find that a lot of relationships you're into that are supposed partnerships, those qualities are not actually there. Openness, integrity, and confidence. So trust, in my mind, is born out of confidence, truthfully, at the end of the day. Do you have confidence that the people will act in the spirit of the partnership, in the spirit of the common objectives, and work to a solution together rather than purely protecting their own interests? And regrettably, we have a number of examples in health IT where those things are not true, and therefore that is why this made it to the top 4 list. And at the end of it all, can you measure what you've accomplished in terms of a health outcome, not just in terms of meeting contractual SLAs, like boring. SLAs are a process. Can you actually measure the outcome, which is truthfully the benefit of why you would actually do something different that is scary and risky and you're not really trained for and not in your DNA? So we introduced the concept of a P4. And the recognition with this was that the interests of government, the funder, and the interests of the health authorities, the service delivery folks, were not the same. And that came out through the interviews, as you'll see, that in fact, in some cases, government's interests and private sector interests may be better aligned than the interests of government and the health service delivery organizations. Okay? This may be kind of obvious to you guys, but we thought it important to call it out. So, oops, I'm going the wrong way. So what we did is through our interviews, we developed against these 4 axioms different perspectives of each stakeholder. And I think I'm going to go to the next one, yeah, because it's easier. So what's shaded here are the areas where there was a common interest. So for example, if you look at sustainable funding, the interests of the hospitals and the private sector were more aligned than the interests and views of government. So the point here was, and Leon referenced it, government can go to the bank and get money cheaper than I can as TELUS, or he can. And that's a fact. But it's also not the most important fact. The more important fact is, can you get access to that money over time in exchange for some sort of risk transference? And that is valuable beyond the fact that there's a point or two on the rate of your financing. Okay? So here we saw the hospitals or health authorities and the private sector more aligned on this point. If you go to governance, we found that there was an alignment between private sector and government. Why? So the only effective way to implement any form of HIS across multiple parties is some sort of standardization, standardized protocols, standardized processes, some sort of common implementation. So government gets that because they want kind of one, and private sector wants that because they want to leverage one across multiple and not have different standards and different this, that's, than the others. But hospitals are not aligned on that one because they're all special and unique, right? So patients on Vancouver Island are different to those in Fraser. Like, I've been told this. Government doesn't agree and the private sector doesn't agree. So we get a misalignment there, if you will, with the health authorities. Anyway, you can see where the thoughts are going. The thought was you needed this P4 concept to recognize the different interests of government and the service delivery organization. Maybe the last one I'll point out is the outcomes, which talks to integration, which I believe is the theme of what you've been talking about. The integration across the continuum of care, very strong interest of the private sector, because we believe that's where information technology can actually add the most value, is the connectivity. And interest of government, who are trying to align the silos of the health system, and I use the word loosely, the loose collections of services that are called a health system. Whereas in a hospital or health authority, they got a service they have to deliver and a price they get paid to deliver that service. So you see an alignment between government and private sector, but not necessarily the hospital system. So what did we take away from that as, what will it take to enable sort of P3s? So on the sustainable, I've kind of already made the point that it's not about just the cost of capital. It's the ability to index funding to ongoing, fresh, sustainable solutions that integrate across the space. Governance, we need to be able to look at standardized workflows, and it's easy to put on a chart, and I know it's difficult to do. But unless we confront that issue, we'll never get the value. Okay? So that was a conclusion. Partnerships and trust. Accept and understand the core competencies of each partner. So I personally believe that the public sector does not get the value out of its relationships with its private sector partners. Partly there's procurement rules, and partly there's optics, and there's SLAs and all that other stuff. But do they take advantage of the DNA of the private sector partner, the DNA of an organization that's used to taking risks, that is used to getting its money based on adoption, not based on delivery, but based on people's adoption and continued use and so on of solutions, the cloud or SaaS model, if you will. The only way you make money in private sector in SaaS is more people use it more often, and they consume more of it. So take advantage of that sort of competency or DNA, which frankly is not the DNA of government, let's be candid. And in some respects is the antithesis of the DNA in a health system, where more consumption does not necessarily equal more money. So you want to drive down consumption. So it's a very skewed model. Point is, look at the competencies of each organization and take advantage of them. And then lastly, in terms of obviously outcomes, take advantage of the solutions that enable care to move across the continuum. So what did we think needed to change? And this probably sounds like a broken record, but procure for what, not how. We probably all run into this in whether you're in the procurement in the buying business or the selling business. We tend to have driven ourselves into more and more degree of specificity about something that's less and less relevant over time, as opposed to procuring the what outcome you want. And we're not saying these are easy things to do, but these were the observations of the group. Adoption, driving adoption, which obviously drives the business model associated to SaaS or cloud solutions. Building in innovation, so forced innovation in a contract can be done. I've seen contracts where there is a requirement for a cost reduction over time that the vendor will sign up to. And to do that, to get that cost reduction, they have to innovate, and they have to improve the infrastructure and innovate at the same time and drive down the costs. Private sector typically isn't scared of those sort of things. And then lastly, in terms of accountability, it's not about price, it's about value. And that's kind of obvious, I suppose. And ensuring that there are appropriate incentives and penalties. So incentives based on adoption and increased value delivered, penalties in terms of misses. That equation seemed to balance out. So we kind of phrased this as, can we agree to the following? We need to rethink the methods of procurement. And actually, it's funny, when I say rethink, it's not actually rethink, because many of the, quote, new ways of procurement, like joint solutioning and so on, have been around for years. We just seem to have fallen off the wagon. Link governance to standardization and adoption, and ensure those components are aligned. Build in innovation and expectations of innovation right up front, so that involves less specificity, more open, but more about the what, not the how, and a shared commitment to accountability, sort of mutual accountability with an effective governance structure. So that was what our group came to. Look, it says 0.00. Did I hit on time or what? So thank you.